Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
What I learned in fellowship is completely different than what I know now. And I passed the boards. I did well on the boards. Yeah, I stressed about them. But the boards do not define who you are as a cancer doctor. They are just a step along the way. And so really, I am much happier if a fellow has that thought process and that self-reflection and knowledge of what they do and do not know. They're going to be amazing when they're done.
Hello and welcome to the ASCO Education Podcast. My name is Aakash Desai and I'm a Hematology Oncology Fellow at Mayo Clinic in Rochester. I will moderate this episode focusing on how oncology training has changed in the last couple of decades. Do you think today's fellows have it easier with the electronic medical records, or is it rather harder with that? Given the much bigger pool of treatments to choose from and the constant stream of information, is it more difficult for oncology fellows in this day and age? On a personal level, what challenges persist? How might we reimagine oncology training in the future? To discuss all these questions and more, I'm joined by current oncology fellow Dr. Madison Conces from Cleveland Clinic and two former fellows, Dr. Lori Rosenstein, hematologist and Hematology Oncology Fellowship Program Director at Gundersen Health Systems in La Crosse, Wisconsin, and Dr. Deepa Rangachari, a medical oncologist, assistant professor of medicine at Howard Medical School, and Director of Hematology Oncology Graduate Medical Education at Beth Israel Deaconess Medical Center in Boston. As we're all colleagues, I'm going to refer to everyone by their first names, if that is okay. And so I'm going to pose my first question to Madison. Question is, what motivated you to get into medicine and specialize in oncology? And then I will have Lori and Deepa answer the same.
Thank you, Aakash, for having me join this conversation today. So I would say I'll kind of answer the medicine and hematology oncology portion at the same time. I was in college when I actually was shadowing Dr. Pat Laird at IU over the summer, and I worked in the lab while also doing clinic with him 1 day a week. And I think being able to see the science and working to improve patient care while also witnessing the patient interactions and the relationships and the trust between the physician and the patient is something I really admired and that really drew me. So I think that's kind of when it first sparked. And then just during residency in medical school, my recurrent interactions with oncology patients is what kind of definitively made me go that route.
Lori?
So I was a little bit slow to figure out what I wanted. I thought neurology or internal medicine, and then I had no plans after that. And I really debated a long time. Ultimately, now that I'm a hematologist, and this is totally makes sense with my personality and everything else, what I love about hematology is the mystery and the detective work that happens. It also happens in neurology. That's what I liked, was figuring out where the lesion was based on your exam. But in hematology, we figure out where the lesion is, and then often we can fix it. And to me, that was really exciting. So I joke with my fellows all the time that I'm a blood detective. And the best thing ever happened yesterday is that one of my fellows knocked on my door and she came in and she said, "Today I'm a blood detective. I figured this out." And it's super cool. I think that's a really fun part about hematology and oncology.
How about you, Deepa? What are your thoughts on this?
My inspirations mimic those shared by my colleagues already today. At a very young age, I had a very dear family friend whose mother is a pediatric hematologist oncologist. And I think I was immediately enthralled by her demeanor. And later in life, as a medical student, I had the opportunity to shadow her and really see her in action. And I think she really embodied all of the things that I always considered in terms of being a consummate physician. And I think on a daily basis, what inspired me to become an oncologist is really what to this very day holds me deeply and devotedly to this lifelong career, which is the ability to exhaust and frankly apply all of my intellectual, emotional, and interpersonal skills to achieve the best possible outcome for a patient and their loved ones in what is often very challenging and or devastating circumstance. The inspiration in many regards from years ago is the ongoing inspiration even today, and very much informed by early experiences seeing such folks practice in a way that I felt was truly the art and science of medicine.
I guess the next question I would want to ask is, what is the most rewarding part of the fellowship, Lori?
I hate to say this. I'm the oldest one of the group here, so I've been the longest since I did my fellowship. But I will say the best part of being a hem-onc doctor is the longitudinal relationships that you develop with those patients over time and the difference that you make in people's lives in the really short amount of time that sometimes you're with them. I think fellowship, we'll talk later about the stresses and difficulties of fellowship. But knowing that you're in that final stage, everything up until fellowship is I'm doing this to do the next thing. I'm doing this to do the next thing. There is really not a next thing after fellowship. That is what you're going to do. And I think that's the most exciting part is everything you're doing is for that purpose, once you pass the boards.
I agree with what Lori just said. And I think as someone who's in their final, I'm a third year Onc Fellow right now. And I would agree where you're just like, this is it. This is what I am going to do for the rest of my life. And there's excitement with that. There is a little bit of anxiety, I guess, under it, but there's a lot of excitement with it. And I think like when I sit and talk with patients now, I know we keep kind of reiterating the human connection, but I feel like at least as a fellow now, I'm able to explain things or understand things in a way I didn't before. And I feel like that makes me even more connected in their care. And also in a way kind of, I wouldn't say understand because I'm not in their position, but I'm able to, I feel like, meet them closer to the middle than I was before. So I really appreciate that, I guess, growth I've had during fellowship that's allowed me to, I think, be closer with patients and in their journey.
Madison, this is Lori. So I was just going to ask based on that. I see externally as my fellows are going through their training, there's usually just this moment where I can suddenly see that it's kind of clicking and the hardness of first becoming a fellow all of a sudden starts to get easier and they really start to fly. They start to do fantastically. Do you remember if that was something that you experienced?
I think so. I was on Oncology Consults August of my first year fellowship, and I am September of my third year fellowship. And I just noticed how quick I can be. Like in July, I was like, oh my gosh, I'm a third year. How am I going to be ready for next year? But now that I'm on Oncology Consults again, seeing every type of solid tumor malignancy, specifically for solid tumors, obviously, but I see the pace I'm going compared to before. I know the depth of knowledge I have is much greater. I kind of am more aware of my deficits of knowledge. So I definitely feel, I would say just even in the past week, I've noticed like, wow, I've definitely gotten better. I don't know if I'd call it an aha moment, but I've definitely had that perception of myself in the past week.
Yeah, I think as a third year fellow myself, I agree. I think that's, very rewarding. Essentially recently I was giving a talk to our first year fellows as a primer talk on lung cancer. And, I realized like some of this comes so naturally to me now. And I remember myself being a newly minted first year fellow and just thinking like, how am I ever going to make sense of all this data and everything that's coming out? That's also, I think, the part of the personal growth you grow as a fellow. I think it's also very rewarding as a fellow that I've found. So with that, I think one other thing that's been, obviously more recently brought out is resident burnout, fellow burnout. Just in general, physician burnout has been the theme, and we are becoming very aware of this. And I think fellowship being a training, it obviously has its own stressors. So what are the most stressful aspects of fellowship that you found? Tell us about the most stressful day you've had so far and how do you cope with stress and workload, and any tools or strategies that you would recommend to current fellows and other peers that could be useful?
I would say probably it's twofold in terms of what's most stressful about fellowship. Like one is the information, which you had already mentioned, Aakash. And I think with that is kind of the research aspect and balancing that, like how do we dive into research and look into spaces that are unknown, if you will, and then at the same time know the data of the cancers we're already treating. And then I think the outpatient stresses are different from the inpatient stresses in a way, because I think during inpatient, you're constantly engaged in these difficult situations patients are in. and there's not much of a break. And so I think sometimes, not that we don't have difficult clinic days, but I think there can be a little bit more emotional drainage. And I think in terms of trying to deal with that stress, like you mentioned, so I'm a distance runner. And so even when I'm on service, I actually still make time for a run, even if it's just a quick run in the evening, or get it in before work if I'm on call that night, or something, sometimes just some light weights. That's been my crutch, if you will. I've done that all my medical training. I've been running for most of my life. And I've been very deliberate and diligent about continuing that. And I think that's somehow kept my head above water some days. I do wonder what else I could do to help, because I definitely have days where I feel like my running isn't enough. I think, as many people have felt since the COVID pandemic started, there's been a real struggle with burnout.
Lori?
Yeah, I think there's a lot that's stressful about Onc Fellowship. And as a program director, you see the cycle. First year fellow comes in, they're brand new. That first 6 months, as I said previously, is just so hard. And you as a program director want to help, you want to get them through that, because, many people are coming in. It's a new hospital, it's a new system, it's new diseases. It's working in the clinic instead of the hospital, which in most internal medicines are very, very hospital focused. And then all of a sudden you're in a clinic where it's almost all outpatient and you don't know how that works, even though you should. Like, people think I could be an internist, I could be done. And yet all of a sudden I'm right back at the bottom of the barrel, so to speak, not knowing how to do anything. And so that first 6 months for sure is really stressful, because you feel like you've had autonomy when you're a third year resident, you're ready to go out, and then boom, you don't know what you're doing again. And so at the same time, you are a young adult who often is having families, thinking about settling down, buying homes, growing up. And that just adds to all of the stress, because you have the stress at work and then potentially stress at home. For me, I had my first child when I was a resident, and then had my second as a third year fellow. And so I had these different stresses as I was going through my training. Some of my fellows have had parents die while they've been in fellowship, or parents that they're helping to take care of. So not only are us older people in kind of the sandwich generation, but I think younger people in fellowship are seeing that as well. So yeah, I think there's a lot going on that can make it challenging. But my encouraging part of it is that it gets easier. You start to figure out where you can find the information that you need, how to make things happen. And there's just this tipping point where suddenly it becomes easier. And then I see that they're back having fun again, that this is such a really interesting disease. And I've never seen this presentation before. And I looked in the literature and there's only 3 cases. That passion and then excitement for finding new things. Or, I wasn't sure if this chemo was going to work, and I gave it, and they're back today and they are so much better. Just that excitement and passion. It's so wonderful to see as a program director.
The other thing is also, I feel like the stresses are different as you kind of evolve through your fellowship. So I think, as Lori very rightly pointed out, like the first year is, just getting used to the information, the flow and everything. But what I found particularly challenging is, as you enter like the second and a third year, and when you have patients that you continue to follow, just by the nature of the disease and the field that we are in, you will end up having some patients who you lose along the way. And I think that dealing with it emotionally, I think, because during the first 2 years of your fellowship, you meet them every few weeks, you kind of get attached to them and you know what their life is like. You share part of your life with them. How have you found your way of coping with loss of the patients that you kind of have a deep connection with? I think that's part of the stressful aspect of like later years of your fellowship, I feel. Any insights on that, Lori? I mean, you've obviously been doing this much longer than me and Madison, and how do you deal with this kind of loss and keep going every day even with the same enthusiasm?
Yeah, I think that absolutely is a really challenging part of our field, but it's also part of the blessing of our field is that we are there and we can help negotiate people through difficult times. And if we're doing this well, we have seen this coming. We have been able to prepare people. We've been able to make sure that we're honoring the things that are important to them at the end of life. And We're working to make sure they're not in pain and that they have their family members near them. And so for me, that's always that rainbow at the end, is that I was able to assist them in this process. We all know we can't stop death. We may, fool ourselves into thinking this carboetopicide is going to change the world for this patient. But I think being realistic about what we can and cannot do, for me, having a great conversation with a patient and their family and knowing that I've helped them, even if the end result is not that they have another 20 years to live, is super meaningful. And I think most oncologists that can do this for a long time find the value and the meaning in that part of their job. I think if you're constantly trying to stop death and trying to continue chemo till the very bitter end, this could be a very draining job.
And more we're realizing the importance of supportive care in oncology. And I think what you just pointed out is that, improving someone's quality of life even for 2 months is also very rewarding in its own way. So thank you for saying that. The next question I have is especially, geared towards you and Deepa for fellowship program directors. How has oncology training changed since you were a fellow? And is training for current fellows harder or easier, do you think?
Any program director who trained a long time ago will give you the woes of, I had to walk both ways with the no boots and snow. No, I think that probably the biggest change since I was a resident is work hour restrictions, which came sometime during my residency. So I was a fellow when there were work hour restrictions. But to be very honest, in fellowship, you almost never are reaching that 80-hour work week like you would have been when you were on an ICU rotation in internal medicine. Most of my fellows, they log their hours every week, and we're somewhere around 40 to 45 hours a week, depending. There's going to be times where it's busier. So I think the work hours are less of an issue, but that doesn't mean it's easier. And I think now the most difficult challenge is all the new treatments, all of the options. It used to be we had two choices. You could do this or you could do this. And now there's all these nuances, and nuances are very challenging when you're first learning. You can see this study and it was this compared to this, and option A was better. But then you talk to your attending and they say, well, option A was better unless you were from some esoteric country and then, you did worse. So you start to really piece apart and, you gain your basic understanding, but then start to try to apply that to your patient. And that is, I think, a very big challenge.
How about you, Deepa? What are your thoughts on this?
I think it's become harder in that it's become incredibly more nuanced and incredibly more sophisticated. Three things in particular come to mind. One, sort of the burgeoning evidence basis for what we do and the prospects for advancing our knowledge and understanding and thereby have better interventions. It's certainly been a seemingly explosive growth in our knowledge and understanding, especially considering the humble origins of our field. I work daily with colleagues and friends who remember those days when Hem/Onc was sort of an esoteric field of people whose methods were considered bizarre at best. And that's absolutely not where we are anymore. It's an incredibly exciting time. So a lot of information to keep up with. Secondly, one of the things that maybe we didn't really appreciate at the time was true before, but is increasingly true now, is the importance of recognizing your role as the leader of a very sophisticated interdisciplinary team. Thankfully, I think this is true for all patients with any illness, but thankfully in our disease area, care by an expert village is really the norm, not the exception. And sort of learning how to function in those interdisciplinary teams in an incredibly collaborative and productive way across the spectrum of a patient's care and needs is incredibly nuanced, more so than ever before, and something that fellows at the earliest instance of their training really need to learn to be agile with. So I think that's something that is also both a sign of progress, but also an added layer of nuance and sophistication. And I think the final thing is that there are so many diverse ways in which someone can have a truly impactful and fulfilling career within Hem/Onc. And I think this makes fellowship also that much more exciting and complicated, nuanced, really trying to understand within your career span, what is the pathway or the different pathways, honestly, that you may choose to train and prepare for and conduct yourself is really dizzying. And I think we really are expecting a lot in terms of our fellows these days to sort of be willing to understand those options and understand which options are most meaningful to them, and then prepare in a very deliberate and rigorous way for those specific career interests. So kudos to all of you. You guys are doing an incredible job. You're the future of our field. And those of us who run programs, direct such programs, we really have a continued challenge and inspiration to meet your needs.
The field is moving so fast that I can say, like, when I joined fellowship in first year compared to now, I think there's a lot of more treatment options. And I think as fellows also, it's so difficult to keep up with this, constant stream of information. So Madison, how do you think things have changed since you joined fellowship, and how do you envision yourself, resources to use to kind of keep yourself updated?
I would agree with both of you. It's definitely changed. It's also interesting because it's not always the addition of treatments. It's sometimes showing that adding this extra drug does nothing. And so all of a sudden, you've now changed the paradigm again for how you treat that patient. And I think for me, what I found during fellowship is, and maybe Lori would enjoy this part, but the thinking of it, right? So even hematology, I definitely think of as the puzzle, but in general, all these patients, there's something about them, other their tumors, genetics, or the family history, or any of their germline mutations they have. So there's always this kind of, every patient is very specific. And so I think what has helped me, at least during fellowship, is in clinic to go through that in that mindset with the staff I'm working with. And I think sometimes, at least I've been fortunate to have staff who do a great job of making sure I'm thinking of everything, which is like, oh, if this doesn't work, what do you want to do next? Which makes me think about, well, what do we know about the patient? What do we know about their tumor? What are the other options? I'm someone who learns by doing, which I think is many of us at this point. And so I think the constant feedback from staff of kind of pushing us to think on our own is going to be helpful in the long term, rather than expecting us to come in remembering, every part of the NCCN guidelines, because those are going to change as well. So we've really got to be able to think through these patients' cases like puzzles. And also, a lot of these patients don't read his textbooks a lot of times. Lori was talking about seeing the excitement of her fellows again. Yesterday I saw a patient who has a paraneoplastic related nephrotic syndrome. It's like these things, we have to be able to keep pace with essentially our patients and their pathophysiology. And the more we learn, the more kind of breadth that's going to be. It's going to be wider and wider in terms of what we have to know. And I'm not sure knowing it all is going to be the way to go. And for me, I try to know the basics, and then beyond that, really look at the patient, and instead of thinking about every treatment for that, whatever cancer of the patient, look at what do we already know about it and what can I go from there.
That's so interesting, Madison. And Deepa and I had talked about this, as program directors. My goal for fellows is that they learn how to think about cancer and how to have a really regimented way of going through a new patient and thinking through, do I have the diagnosis? Do I have the stage? Based on those things, what do I know about the patient and their disease to make my treatment plan? And that's the same for every cancer. Essentially, you're going through this regimented process. If I have a fellow that I know can think through a cancer, to me, it doesn't matter if they know that Merkel cell is associated with the Merkel polyoma virus. They may never see a Merkel cell, or they may see it once. So that regurgitation of information that you are so used to doing for boards and for tests is, to a program director, is really so much less important than, can you think through the process? Can you find the own holes in your knowledge base? And then can you find where to fill those holes so that you can take great care of patients? If I could tell any first year fellow coming in, don't panic about your knowledge base, because what I learned in fellowship is completely different than what I know now. And I passed the boards. I did well on the boards. Yeah, I stressed about them. But the boards do not define who you are as a cancer doctor. They are just a step along the way. And so really, I am much happier if a fellow has that thought process and that self-reflection and knowledge of what they do and do not know. They're going to be amazing when they're done.
This kind of reflects how the program directors in our field actually, are thinking beyond just like, oh, you need to score good on the boards, because they realize the importance of thought process and how to come up with treatment plans. So Thank you, Lori. I think this is phenomenal, and I'm sure all the fellows listening to this podcast will be delighted to hear what you just said.
Now, you still have to pass the boards. That's still a key component. But I think if you polled program directors about what we think about board passing, most of us would say it's probably 6th or 7th on the list of importance.
Yeah, I would actually add on to that. We've been talking about thinking through processes and through these cases and using, the thinking process more than just memorization. And I think also in fellowship, we are trained to also have these conversations with patients, right? Because it's not always what would be the right answer when we think about it in a treatment sense, but if that doesn't match what the patient wants, then it's not the right treatment. And how do we adjust that based on what's in the patient's best interest or what the family wants, depending on what the situation is, obviously. I think fellowship is it's about this critical thinking, but also in the context of the fact that we're taking care of this human being in front of us.
Well, this concludes part 1 of our discussion on the past, present, and future of oncology training. My guests have been Dr. Madison Conces, Hematology Oncology Fellow at Cleveland Clinic, Dr. Lori Rosenstein, Hematology and Oncology Fellowship Program Director at Gundersen Health System, and Dr. Deepa Rangachari, Fellowship Program Director at Beth Israel Deaconess Medical Center. In the second part of this episode, we will explore the different ways to stay current with new treatments and guidelines, as well as our guests' insights into how oncology training should look like in the future. Thank you to all of our listeners for tuning into this ASCO Education podcast. If you have an idea for a topic or a guest you'd like to see on the show, please email us at education@asco.org.
Thank you for listening to the ASCO Education Podcast. To stay up to date with the latest episodes, please click subscribe. Let us know what you think by leaving a review. For more information, visit the Comprehensive Education Center at education.asco.org.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.